Okay, fluid electrolytes, we'll start with the exemplars a little bit later. So let's begin with the concepts first. So when we think about fluid electrolytes, let's look at it in context of the human body. So humans are made up of between 70 to 80% water. 80% water in the case of infants, 70% in case of adults. Okay. So there are two major compartments. So water can either be inside the cell or it's outside the cell. Okay. When it's outside the cell, there are two subcompartments. So it's either in the blood vessels or somewhere in between cells and blood vessels. All right. Again, there are two major compartments of water in the human body. Water can either be inside the cell or it's outside the cell. When we say outside, there are two subcompartments. It's either inside blood vessels. When we say blood vessels, we're referring to arteries, veins, capillaries, and lymph vessels. And the other subcompartment is if it's not inside the cell, it's not inside the blood vessels I mentioned, so they must be somewhere in between. Now, this is a dynamic fluid compartment, meaning water does not sit in one place. Water constantly moves from one compartment to another. So water will move from the interstitial to the intravascular or into the intracellular compartments. The movement of that water is influenced by several factors. So we have two methods of fluid movement. It's either active or passive. Now, most methods of water movement are passive in nature. So let's look at it in the next few minutes. So I already mentioned that these are the three places you can see water. It's either outside the cell, meaning it's inside blood vessels. They're not inside the cell, neither are they in blood vessels, so they are in the interstitial spaces, okay? In between cells, in between capillaries, or they're inside the cell. Now, when we say fluid loss, there are two types of fluid loss. There is absolute, or there is also relative fluid loss. When we say absolute, the fluid left the body. How does it leave the body? Through breathing, through vomiting, through urinating, through feces, through sweating. Okay? So these are ways that fluid leaves the human body. However, there's also what we call a relative fluid loss, meaning the water technically is still inside the human body, but it's neither inside the cell, it's not in the blood vessels either. So it's somewhere in between, which is the interstitial space. Now, the interstitial space is supposed to only hold a certain amount of water. Water is not supposed to be in large quantities in the interstitial space. When that happens, now there are two methods this can result. There are two processes here. When we say edema, the water is in the interstitial space. We have large amounts of water found in the interstitial space. Now, this is, of course, abnormal. Now, there are two ways that this can form. It's either caused by hydrostatic pressure, meaning if you have fluid overload and the blood vessels has reached its limit as to how much fluid it can hold, water will leak out of blood vessels. They can leak out of arteries, veins, capillaries, or even lymph vessels. You follow so far? So that's one way to push water out into the interstitial space. Through what method again? Hydrostatic pressure. Okay, hydrostatic pressure, meaning increase water pressure inside blood vessels. Okay, so that usually happens with fluid overload conditions. or venous congestion conditions. Now, when we say third spacing, this is still edema. However, edema is formed by hydrostatic pressure, meaning if the pulmonary veins, for instance, are filled with too much blood in a fluid overload condition, let's say in heart failure, so it will push water out. So water will stay in the lungs. So the lungs filled with water. That is edema. Edema can also form in the peritoneal cavity. In the case of, let's say, people with liver failure, wherein the liver is basically cooked, so the portal veins become congested, they will leak water out. Now that is all caused by what process again? Hydrostatic pressure. Okay, congestion. When you put too much blood volume, of course blood will not leak out of blood vessels, only water will leak out. Okay, so you understand edema. Now when we say third spacing, this is a completely different process. Yes, the water is still in the interstitial space, but the difference is how did it get there? Now, third spacing is not caused by hydrostatic pressure. This one is caused by imbalance in the concentration of the plasma. Usually, when we say third spacing, this occurs in the following examples. When we have ascites, pleural effusion, angioedema, or even in burn patients. Okay, so these are the examples of third spacing. Burns will also be included here. Now, how did third spacing, what makes third spacing different from edema, which is caused by hydrostatic pressure? Third spacing is, as I mentioned, this is caused by imbalance between the concentration of the fluids. Okay, now plasma, what is plasma? What is plasma? Anybody? Can you, Esther? You made eye contact. You said, pick me, pick me. Say again, the. Okay, that's one component of plasma. You're referring to actually not stop, but rather allow blood to clot, right? Okay, so plasma contains clotting factors. Okay, so but that's not what I'm asking. So where can you find plasma? Which part of the blood is considered plasma? Okay, so blood is mostly water, correct? It's 70% water, and then there are suspended blood cells there. There's white blood cells, red blood cells, platelets, and there's plasma there. Plasma is mostly water. Plasma is the liquid part of your blood. So if we get a blood sample from you, I fill a test tube with blood, and I spin it in a centrifuge machine, it will separate the cells from the plasma. Now that yellow clear part is called plasma. So what does plasma contain? Mostly again, water. Now, what makes water stay in the blood rather than elsewhere in the body? Why does blood hold on or is able to hold on to a certain amount of water? That is made possible by albumin. Plasma is 70% water, it's about 20% albumin. So these large molecules of protein called albumin is what holds water inside plasma. So whenever we have a condition wherein, name a few conditions that can cause proteins or plasma or albumin in the body to be low. Malnutrition, okay? Alcoholism. So mostly malnutrition episodes, which includes cancer patients or alcoholics, for instance, they are considered malnourished. So all malnourished patients have low albumin. And also, you remember nephrotic syndrome? You're still taking pediatrics now, eh? Okay, so never mind. Another example is nephrotic syndrome. Nephrotic syndrome, those children lose proteins through the urine. So these patients are have hypoalbuminemia, meaning they have low serum protein. So whenever this is the condition, and the fluid, the edema, enters the interstitial space through this mechanism, through this process, then we call it third spacing. So you understand now the difference between edema and third spacing? Will they look different? No, they will look exactly the same. The difference is, how did that edema form? Any question? Difference, what's in your own words? How did edema occur? Increased hydrostatic pressure. How does third spacing occur? Okay. Albumin is low or albumin leaked out of the blood vessels. Okay. Okay, we'll get more examples later about how does albumin leave plasma. Okay, how do they leave the intravascular compartment? So here's an illustration again of the distribution of water throughout the body. I'll talk about electrolytes one at a time later. All right, so let's look at factors that will affect the movement of water. One is osmosis. Now, of all the passive fluid movements, osmosis is the largest influencer. Okay, you understand who influencers are, right? They're very popular. So the major influencer of fluid movement is osmosis. Osmosis simply refers to the concentration of a solution. Now, what do we mean by the concentration of a solution? What are we really referring to? Say, compare a cup of coffee versus a cup of plain tap water. Which one is more concentrated? Okay, so again, osmosis refers to the concentration of a solution. What made you say coffee is more concentrated than tap water? What made you say that? Okay, so the more solutes suspended in a solution, then the higher the concentration. So concentration basically is what osmosis means. Okay, so as the concentration of a solution or compartment of the body, so what are the three compartments of the body again? We have the intracellular. When we say extracellular, what are those two? Intravascular or in the interstitial. Okay, so the concentration of these three compartments, do they remain the same all the time? No, they change constantly. Okay? So from 1 minute to the next minute, it will change. So you may be fine right now, but later, after an hour of me talking here with no potty breaks, will the concentration of your fluid compartments change? Yes. Okay. So these terms mean the same thing. Okay, so osmosis is the process, osmolality is the concentration, so is osmolarity. Okay, they just refer to the what type of fluid we're talking about. On your own, please watch this animation. I don't have time to play it right now. So I already mentioned hydrostatic pressure earlier. So what does hydrostatic pressure result in? Okay, if the concentration or the pressure of blood inside blood vessels is too high, then that will cause hydrostatic pressure to rise and pushes out water out of the blood vessels, especially the capillaries. For testing purposes, these are the values that we will use. I know you work in different facilities. So for those who work in hospitals, we will not use your hospital's normal ranges. What will we be using? Table 10-1. So this is your textbook's range of electrolytes. So this is what we'll be using for testing purposes. Now for exam 1, let's take it one at a time. Now, what's relevant with the exemplars we will be using this for exam 1 are sodium and potassium. And then later when we get to thyroid and parathyroid problems, we will look at calcium and magnesium. Okay, so for exam 1, we will focus on sodium and potassium only. Okay, so baby steps at a time. And these are the ranges we will use: 135 to 145 and 3.5 to 5 for potassium. Here's an illustration of osmosis. So what does osmosis say? If you remember from Dr. Farrington's class, water will move from where to where?
I don't know.
Okay, so water will move from an area of lower concentration to an area of higher concentration. So here's the illustration. So why did the water do this? Why did water move from an area of lower concentration or lower osmotic pressure or lower osmolarity to an area of greater concentration or greater osmolarity? What was it trying to do? Okay, it's trying to equalize the concentration of fluids between the compartments. Okay, so that's how our body works. So the human body always wants to maintain the same concentration among all 3 compartments. Now, among the contents of a solution, what is able to pass through? Smaller or larger molecules? Only smaller molecules. And the smallest molecules, of course, in this particular situation is water. Okay, so water molecules can easily move between compartments through the semi-permeable cellular membranes. So in order to equalize the compartments, water has to move because it's harder to move larger molecules, especially protein or blood cells, okay? Because they're too big. It cannot pass through the cell membrane. Okay, next, let's talk about IV fluid shortly. So why do we use certain types of IV fluids in certain conditions and why? Tonicity, this is still again referring to the concentration. All right, let's talk about IV fluids now. Now, the tonicity or the concentration of a solution, or in this particular instance, we're talking about IV fluids, IV solutions. There are 3 types of IV fluids according to tonicity or concentration. Isotonic, example is R, 0.9% sodium chloride. We have a table. We'll look at the table shortly. The same concentration, isotonic solutions have the same concentration as the blood, as plasma. Okay, exactly the same. So therefore, when you infuse isotonic solutions, since they have the same concentration as plasma, when they enter the bloodstream, where will they go? They will go nowhere. They will stay in the bloodstream where you put them, right? So what type of, so here, isotonic solutions therefore do not provoke water movement. Okay, they will stay where you put them. So what type of patients will benefit from isotonic solutions? Okay, so there are 2 types of dehydration. So we have simply water loss, and there are also solute loss. Okay, so when we say dehydration in this particular example, we're simply looking at dehydration with purely fluid loss. Okay, there is no electrolyte loss. Okay, so examples here are when you're, let's say, running a marathon, or let's say it's too hot outside. Okay, so you're losing water, right? So that is the type of patients that will benefit from isotonic solutions. So again, we have a table. So it's not just 0.9% sodium chloride, or we call this saline, correct? Normal saline. Okay. So therefore, this type of solution will expand plasma volume. Okay, so if you want to increase blood pressure, for instance, or you simply increase intravascular fluid volume, then this will be your choice. Okay, so someone who is bleeding, can this be administered? Yes. Okay, because it's not easy to get blood. Okay, we need to type and cross, we need to cross match, so therefore blood transfusions will take time, right? In the meantime, to maintain blood pressure, you can give the patient what type of solutions? Isotonic. Okay. So isotonic solution examples are normal saline, D5W or D5 water, and also lactated ringers. Okay, so those are the three um, isotonic solution examples. Let's go to hypotonic now. So the examples of hypotonic solutions, well, from the name itself, hypo, so if 0.9% concentration is iso, then that means anything less than 0.9% must be hypo. Okay, so here are two examples of hypo, either half normal saline or a quarter normal saline concentration. Because they have less concentration compared to plasma, where will this go according to osmosis? So when you administer half normal saline or quarter normal saline, a hypotonic solution, into the bloodstream, according to father osmosis, this will go where? Will it stay in the bloodstream? Will it go out of the bloodstream and into the cell, or will it pull water out of the cell into the bloodstream? What did osmosis say again? Okay, so water must move. Okay, it will not request. It will say you have to move. Okay, so the body has no choice here. Cannot say no. Water must move. Okay, so therefore, if you put this type of solution into somebody's intravenous compartment, where will this go? Into the cells. So what could possibly go wrong here? If you give a hypotonic solution to somebody, what could possibly go wrong? The cells will have edema, right? This will cause cellular edema. Of course, only if you give too much of a solution. Okay, just like isotonic solutions. What can possibly go wrong? If you give somebody isotonic solutions and then not monitor the effects, you just leave it running shift after shift. What could go wrong here? Yes, we know that. But what will be the effect? Blood pressure will be too high, patient will have fluid overload. Okay, so same thing here. So since this goes into the cells, so what could happen here? If we don't monitor too much water in the cells, particularly in the brain cells. So can this cause cerebral edema? Yes. Finally, hypertonic solutions. So these are solutions that are higher in concentration compared to plasma. So anything higher than 0.9% is hypertonic. So most dextrose solutions, so D5 normal saline, D5 LR, D5 and a half, anything with 5% dextrose or 10% dextrose or 20% dextrose, or in the case of saline, 3% saline, these are all hypertonic solutions. Now, where will this go if you administer hypertonic solutions into patients? Will it stay in the bloodstream only and not cause any fluid movement? It will pull, it will draw even more water into the bloodstream. Okay, so for what purposes would this be given? Anyone with edema? Okay, anyone with increased interstitial space fluids, for instance, it will cause. Okay, so it will draw water out of the cells, out of the interstitial space, and into the intravascular compartment. All right. Okay. Here's an alternative. So let's say the patient has a condition wherein they cannot tolerate too much fluid, but yet they have edema. And you want to, example here is brain trauma. So if you have a stroke patient or a brain trauma, head injury patient, where they have increased intracranial pressure, you want to decrease that pressure, but you cannot give hypertonic solutions. So here's an alternative. We can give mannitol, which is a osmotic diuretic. Okay, this is a diuretic, but this will only decrease cerebral edema. So the almost exclusive use for mannitol is in stroke or head injury, head trauma patients. Okay, so this is an alternative, but has the same effect as a hypertonic solution. Finally, let's look at osmotic diuresis. Okay. The number one example here we can use this in is our next topic, probably next week, is during diabetic ketoacidosis. Okay, so long story short, what is osmotic diuresis? Now what is diuresis? Too much or just right or not enough? Too much, okay, so too much urination. Okay, what does osmotic mean again? Osmotic always refers to, okay, so the water moves from an area of lower to higher concentration. Okay, so therefore this means that the patient is diuresing, meaning the patient is urinating a lot through osmosis. So this means the blood volume is extremely high. And what will the kidney's response be? Normally, if it sees so much blood volume, what will the kidneys naturally do? Release water. Okay, so therefore, this is simply diuresing or excessive urination caused by increased blood volume. Okay, so this will make more sense when we use it as an example when we go to DKA, which again is probably next week. We won't have time today. Any question on osmosis and its application, its clinical application? Is it clear? Osmosis? Don't worry, we have, okay, let's find the solutions. That's a table. I can't find it right now, but we'll show it later. But for now, let's go to, so your isotonic solutions are normal saline, lactated ringers, and then D5W, 5% dextrose in water. Okay, so those are the three isotonic solutions. Your hypotonic solutions, examples here, 0.45% or 0.225% NaCl. Then for hypertonic solutions, it's anything higher than 0.9%. So any solution containing 5% dextrose or higher, including 3% NaCl, are all hypertonic solutions except D5W. Okay, so D5W is the only dextrose containing solution that is isotonic. But everything else that has 5% say dextrose in it are hypertonic. You had a question? Let's go to diffusion. So the clinical application we have here is, unlike osmosis, which is the movement of water, this one is the movement of solutes. Now, solutes doesn't have to be liquid. Solutes can be gases. Okay, so diffusion is simply the movement of solutes from higher to lower concentration. Example is when you put um, coffee granules or juices or sugar into a glass container, for instance, it will diffuse, right? So it will move from an area of greater to lower concentration, resulting in a uniform solution. Example again is gas exchange. So how is it made possible? How do we actually have gas exchange? That made possible by diffusion. So at the capillary level, for instance, when you inhale, since you have 21% oxygen and then less oxygen in the pulmonary vein, so oxygen will diffuse into the capillaries. And on the capillary side, so since CO2 is higher in the pulmonary arteries, then it will diffuse out into the alveoli. Okay, so making gas exchange possible. Diffusion is also happening at the kidney level. Let's say you have too much blood sugar, so that will cause blood sugar to spill out into the urine. And same thing for your waste products also. So you have BUN creatinine will also be diffusing out into the kidney tubules in the nephrons. Okay, so that's how diffusion works. Filtration example here is in urine formation. So one of the job or functions of your kidneys is filtrate formation. Filtrate is, example is, let's say when you have a coffee filter, right? So what does it filter? Larger molecules. So same thing, same idea as with urine or filtrate formation. So kidneys eliminate waste products. Another major function of the kidneys is filtration. The only active, so far, diffusion, filtration, osmosis are all passive, correct? Meaning they do not require any power, any energy at all. They just occur passively. The number one example of active fluid transport is the sodium potassium pump. Again, please play the video. So this is a review of A&P. So we'll talk about the sodium potassium pump later when we go to heart attacks, which is next semester. Okay, so we began the class with fluid movement. So we said concentration in the three compartments is dynamic, so it constantly changes. And there is always intake and there is fluid loss. So how do we calculate intake and output? The measurable intake, of course, are anything you drink, any beverages. Now, can we count how much water you had if you're eating watermelon, mango, papaya, or grapes? So that is not measurable, right? Okay, so because that is from fruits, from food. Beverages, yes, we can. IV fluids or whatever liquid you give into a patient, we can measure that, right? But there are unmeasurable ways of intake as well. And not only from fruits or other foods, but also from oxidation. Okay, so chemical reactions in the body, we also produce water. What about output? Well, the measurable output, of course, is urine. Can you measure water from the feces? Okay. Can you measure water from sweating? What about from talking or exercising? Okay, so we have insensible fluid loss and we also have measurable fluid loss. Okay. Now, the insensible fluid loss is estimated depending on the season. When do you think we will lose more water? During summer or during winter? All right. So it's estimated that insensible fluid loss ranges from 600 to 300. 600 to 900, okay, depending again on the season. We do not estimate it. The doctor will set, especially nephrologists, okay, when they when they give orders for how much fluid to remove during dialysis, okay? Because they're the ones making the decision. So here are the organs of the body that regulate fluid and electrolyte balance. Number one organs are the kidneys. So they're mainly responsible for how much water is retained and how much water to remove. Okay, so there are factors, however, that will influence how the kidneys work, as well as the skin. So the skin, as long as it's intact, is keeping water. So think of the skin as basically a plastic, right? So it's a wrapper that covers the whole body, preventing water from evaporating through our body. Lungs, of course, from when we're talking, okay, when we're exercising. So every time you breathe, you are losing fluids as well. So number one example here is the scene in Titanic with Jack and Rose in the car, right? Remember that scene?
With the condensation?
Yes, on the car windows. Okay, so that's so whatever they were doing there, so you can see there a lot of fluid loss, right? GI tract. So this is influenced by the consistency of your feces. So of course, the more loose your stools are, the more watery, then the more water you lost. All right, so let's look at now indicators. Okay, so how do we know our patient's fluid status? So how do we know whether Joanna has adequate fluid status, or if she doesn't have enough, or if she's having too much, right? So let's examine. So every patient, we'll look at it again in terms of the fluid intake and output, as well as the physical assessment, as well as laboratory findings, okay? For laboratory findings, of course, before we get to the lab, what do you think is the most accurate if we are, let's say, looking at this, for instance? So since water enters and leaves the body constantly, what do you think will be the most accurate measurement? Urine, although we urinate about 1500 ml per day, but what about if I drink too much? Because so does that make urine the most accurate? What about if patients have end-stage kidney disease, meaning their kidneys aren't functioning? Can we still rely on urine? No. Okay, so what would be the most accurate? What if the patient is unconscious? They cannot take anything by mouth unless you put some feeding tube in them. So will that be evidence that my patient has adequate, not enough, or too much fluid? Will it be intake? Will it be output? So what is the most accurate measurement? Oh, is there fluid in the lungs? There's not supposed to be fluid in the lungs. There's supposed to be air in there.
Blood marker.
We'll get to the labs, okay? So I'm just looking at what if we don't have lab results? We just drew it. We're still waiting for, okay. All right, so weight is the most accurate measure. So somewhere in the text in this chapter, it will tell you that 1 pound of weight lost or gain is equal to approximately 500 ml of fluid, of water. Whereas 1 kilogram lost or gained is equal to 1 liter. I'm not on that page, but that's what your textbook says. So that's what we'll use, okay? So therefore, from day to day, when there is a loss or gain of 1 pound, that's approximately 500 ml of water. Whereas if you have 1 kilogram lost or gained is equal to 1 liter of water. You got that?
Yes.
Okay. All right, so let's look at labs now. So first two mentioned here are BUN and creatinine. So what is BUN and creatinine? What are these two? Why are they considered indicators of kidney function? Go ahead. What did we process? That because they're waste products, right? So BUN therefore is a waste product from what? Protein metabolism. So protein metabolism leaves behind BUN. Okay, so therefore, the more protein intake I have, the blank my BUN levels will be. I repeat, BUN, blood urea nitrogen, comes from protein metabolism. So the more protein intake I have, the blank my BUN levels will be. The higher. Okay. So whose job is it to eliminate BUN and creatinine? Creatinine, by the way, is product of muscle metabolism. So whenever your muscles contract, so even if you're just blinking or exercising, we create or we leave behind creatinine. So creatinine is a product. Think of it as exhaust from a car. So after you burn fuel, what you have left behind is creatinine. Okay, so every time your muscle contract, you leave behind creatinine. Okay, so BU and creatinine are both waste products and are excreted by the kidneys. So if I have less fluid in my body, what do you think my kidneys will do? Will they make normal urine, not enough, or a lot of urine? Why? Why did the kidneys do that? Okay, to answer that question, let's leave it for the factors that will affect fluid balance in the body's responses, okay? So therefore, BU and creatinine, when they are high, they usually are caused by the kidneys not making much urine. Now, why did the BU and creatinine rise again? Because they are excreted through the kidneys via the urine. So the more urine somebody makes, the blank the BU and creatinine will be. Okay, let me start over. So how did we know the value of BUN and creatinine? What did we draw? Blood. So we drew blood in a tiger top or red top test tube. Send it to the lab. They looked at BU and creatinine levels. So this is part of chemistry. Okay. So therefore, BU and creatinine, when it's high, where is it high? In the urine or in the bloodstream? In the blood. Okay, so what makes BU and creatinine levels high in the blood? Because remember, the kidneys are supposed to get rid of this. So that means if the BU and creatinine levels are high, then therefore, what are the kidneys not doing? Kidneys are not excreting them. And again, the only way the kidneys get rid of this is through the urine. So if I'm not making enough urine, what will happen to my BU and creatinine levels? it will be high. If I'm making too much urine, what will happen to my BUN creatinine? Abnormally low. Get it? Okay. Another example mentioned here, let's stay with the urine. We have two things here. Urine osmolality, or osmolarity if you want to call it that, or also urine specific gravity. Now let's take a look at it one at a time. Somebody read the statement, please. Sorry.
Monitoring setup.
Okay, start here, Mr.
Urine.
Valadares.
Urine osmolality is determined by urea, creatinine, and uric acid. When measured with serum osmolality, urine osmolality is the most reliable indicator of urine concentration.
Any question about these statements? So osmolality, again, this is concentration. So when we say concentration of urine, what do we mean exactly? What determines the osmolality of any solution again? The number of solutes inside it. So therefore, when we say if a urine has high osmolality, that means what does it contain?
Stuff.
A lot of stuff in it. Hey, it could be sugar, it could be BUN creatinine being excreted, it could also be bacteria, there could be blood in there could be, again, large molecules, okay? Or it could be bacteria as well. What is specific gravity again? Okay, still refers to the concentration of urine, and its normal range is 1.005 to 1.030. Okay, so therefore, when you make less urine, what does it do to the urine specific gravity? It increases it. Whereas if I make a lot of urine, what will be my urine specific gravity? It'll be lower. All right. By the way, you notice I can't read the entire textbook, right? So I'm just pointing out important stuff. So in the test, you have to read the details so that you can answer questions, because I sometimes copy and paste items from the book, especially when it comes to signs and symptoms or findings such as these. All right, we already discussed BUN creatinine and their significance. Where did they come from, and how are they normally excreted? So I mentioned earlier, if a person is consuming a high protein diet, then there is increased BUN levels. Okay. Of course, I was paraphrasing. So here are other factors that can affect BUN creatinine. So if your kidney functions are otherwise normal, but then your patient's BUN levels are high, that may not necessarily indicate dehydration. So these are other factors that can affect BUN levels. So you have high BUN levels when you have the following conditions. Okay, so when you're septic, for instance, okay, we'll talk about sepsis next semester. First module next semester will be sepsis. And also liver disease can also increase BUN levels. And we'll talk about this again. Liver disease will be next semester as well. So I already mentioned creatinine, what it is. All right, other labs are hematocrit and hemoglobin. Between the two, hematocrit is more significant. So what is hemoglobin? Is it just, you mean oxygen? Oxygen carrying component of the red blood cell, right? Okay. What is hematocrit? And why is it expressed in percentage? Hemoglobin is expressed in weight, right? Hemoglobin is measured in grams, right? Grams per deciliter. Why is hematocrit measured in percentage? What about red blood cells? Yes, Gabby? In a given blood sample. Okay, very good. So let's say I have 100 ml of blood. The number of red blood cells in there is measuring hematocrit. Okay, so meaning this is the distribution of red blood cells in a given blood sample. Okay, so what's the normal? Since we have two here because we have male and female, so but the NCLEX patients will not be giving you gender. The patient on the NCLEX exam will simply say client. It will not say male or female. And it's implied, of course, if it's pregnant, then that has to be female. Okay. Well, trans people still can't get pregnant though. So we're still, you know, that's not affected really. So what we'll do here is we'll have to look at the lower and the higher range between genders. So therefore, we'll look at it as 35 to 52. Get it? Okay. Right. So when we say client on the exam question, what range will you use? 35 to 52. Don't worry, the NCLEX won't give you a choice between 35, 33, 34, 42. Okay. They'll either be normal or really high or really low. Okay. So what happens to your hematocrit, which is again the concentration or the distribution of red blood cells in a given blood sample during dehydration? So if I'm crapping, urinating, vomiting a lot, what will be my blood sample when you draw it? Very concentrated because I lost so much water. So therefore, what will be the concentration of red blood cells in that blood sample? Very high. So give me a high hematocrit. That's normal.
So higher than, okay, closer to 60.
Okay, 55, 58, okay, or 60 even. That's very concentrated. You get it? Okay, what about if I'm in fluid overload? What will my blood sample look like when you draw it?
35.
Okay, very watery, right? A very dilute blood sample, so therefore my hematocrit will drop. It will be 30, 32. Okay. All right, let's go to the factors affecting fluid movement. Okay, so we'll talk about one and then we'll have a break. I'll go straight to the mechanism, okay, because it's really a combination of the cardiovascular and renal systems. So let's look at the okay, let's start here. What is the renin-angiotensin-aldosterone system? So there are two parts of this response. So there's the renin-angiotensin, and then there's the aldosterone system. Okay. So what is renin? So this is a enzyme produced by the kidneys. Angiotensin, there's two types of angiotensin. There's one, and then there's angiotensin 2. Angiotensin 1 is from the lungs. Renin is from the kidneys. So this is what's explained here in the lungs and kidney systems. Okay. But first of all, let's talk about the trigger. So when will my body activate the renin-angiotensin-aldosterone system? Okay. All right, so here are the triggers. When the kidneys sense low perfusion, what does that mean? What does low perfusion mean?
Less blood getting to the tissue.
Perfusion, what is perfusion again? When we say blood flow, what is the blood really carrying? Oxygen. So therefore, perfusion means low oxygen delivery. Okay. So this can be either blood pressure is low or oxygen level is low. You agree? Okay, so these are the triggers. It's not only low blood pressure and low oxygen though. It can also be low sodium. Okay, because when your blood pressure is low, oxygen delivery is low. That means sodium delivery is also low, correct? What about if my blood volume is low?
Yeah, blood
Can that
pressure.
trigger? Yes. So blood pressure, blood volume, all kind of go together, right? So those are your triggers. Low oxygen, here, low perfusion, low oxygen, low blood pressure, low blood volume, low sodium, and you can add there low sugar. Okay, although sugar is not mentioned here, but low sugar will also activate the renin, angiotensin, aldosterone system. Okay, but let's stick with because we're talking about fluid electrolytes, so let's look at the four. So the four triggers are low oxygen, low blood pressure, low blood volume, low sodium. Okay, when do you see all four triggers? In fluid overload or in fluid deficit? In deficit, you see one or more of those triggers. Will it ask your permission? Hey, can I activate renin angiotensin system? No, it will activate automatically, whether you like it or not. Okay, it's even faster than diarrhea. Remember the last time you had diarrhea? You think about it, diarrhea, it's already there. Okay, it's in your pants already. Okay, so this one will go faster than diarrhea, faster than a light switch. Okay, this is how fast this will be activated. So the kidneys will secrete renin, and when it meets angiotensin 1 will be constantly circulating in the bloodstream, meets renin converts angiotensin 1 to angiotensin 2. Now, angiotensin 2 is a peripheral vasoconstrictor. What will be the effect of vasoconstriction? Blood pressure will rise. So will it eliminate the trigger? Yes, it starts eliminating the trigger, which is low blood pressure. So when you have vasoconstriction, it aims to increase blood pressure. Okay, so that's the renin angiotensin part. So that's the RA part. Now let's go to the AS part, the AS. Aldosterone comes from the what organ? Adrenal glands, which are sitting on top of each kidney. So the adrenal glands will release aldosterone. And what is the purpose of aldosterone? It increases sodium and water reabsorption. So will it also eliminate the trigger? Yes, same trigger here, low blood pressure, low blood volume, low oxygen, low sodium, eliminated by aldosterone. So you have two systems here, vasoconstriction and sodium and water reabsorption, leading to elimination of the trigger. So again, this response, this mechanism is triggered during what? Deficit or overload? Deficit conditions. Will it wait for your approval? It will automatically happen.
Can you repeat what you just said to, I didn't get that, no, you said two something, aldosterone does two things?
Right here, aldosterone causes sodium and water reabsorption. So when it does that, then of course blood volume increases, blood pressure increases, oxygen, of course, implied will oxygen delivery will also increase, correct? Okay. Because of the sodium potassium pump and the relationship between sodium and potassium, the effect here though is yes, you'll increase sodium levels, but you will lose potassium. Okay, because whenever you reabsorb sodium, that means you have to eliminate potassium. You can't reabsorb both. So if you increase absorption of sodium, you have to release potassium. Okay, so this is the effect. So don't be surprised that when you have patients who are dehydrated, what happens to the potassium levels? They lose it. It drops. Why? Because of the renin angiotensin response. It's a natural consequence. All right. Another response also triggered by dehydration is antidiuretic hormone. ADH comes from the pituitary gland. Its release, though, is controlled by the hypothalamus. So if you read this whole paragraph, it will tell you that. So what is the trigger here? So we know the trigger for renin-angiotensin-aldosterone system. They were the low oxygen, low blood pressure, low blood volume, low sodium levels. What is the trigger for antidiuretic hormone? Thank you for reading, Joanna. Serum concentration.
As serum concentration or osmolarity increases or blood volume decreases, neurons in the hypothalamus are stimulated by intracellular dehydration.
Okay, so therefore, is this triggered by fluid overload or fluid deficit? Fluid deficit again. Okay. So what is the effect of antidiuretic hormone? Unlike aldosterone, which causes sodium and water reabsorption, what is the effect of antidiuretic hormone?
Water loss. No, it's antidiuretic.
It's the trigger. Fluid water loss is the trigger for antidiuretic hormone release. So what is the effect, therefore, of antidiuretic hormone? Okay, causes the kidneys to reabsorb water. You follow? Okay, only water though. However, when we talk about the two disease conditions, which we'll do after the break today, you'll see that yes, antidiuretic hormone does not cause the kidneys to reabsorb sodium, only water. However, indirectly, when you reabsorb water, does that affect sodium levels in the body? As
Yes.
water levels rise, yes, there will be an indirect effect. However, did the antidiuretic hormone intend to do that? No, it only intended to reabsorb water. Okay, however, there's a indirect effect on sodium. All right, let's wrap the last one and then we'll go to on a break. So natriuretic peptides. What are these hormones? Okay, so natriuretic peptides, there are two. We have A, or atrial natriuretic peptide, and then we have B, which is brain natriuretic peptide. If it says atrial natriuretic peptide, where do you think this came from? The atria of the heart. When we say brain natriuretic peptide, where did this come from? Actually, it came from the ventricles. Okay. They call it brain though, simply because they saw it first in the brain. But it's actually coming from the ventricles of the heart. Okay. So let's look at so what would trigger natriuretic peptides released? Okay, let's look at it here. So long story short, blah blah blah. Let's look at it here. Thank you for reading. Beginning here. Up to here. Okay. So from that until the end of the paragraph. Thank you for reading. From here. All right here. Ainur, thank you for volunteering. You made eye contact, so you said, pick me, pick me. Okay, pause for a minute. So based on what you read, what conditions trigger the release of BNP or ANP? Is it dehydration or fluid overload? Fluid overload. That's why it mentions here that this is a because why are we in fluid overload when we are in heart failure? What's the main job of the heart? Pump blood. So if the blood is moving, it's delivering oxygen to the body. What will happen if the pump fails to do its job? So if it's no longer pumping effectively, what happens to perfusion to all the organs? So if the heart is in failure, what happens to cardiac output? Less. What happens to perfusion of all the organs in the body, including the kidneys? It will be less. So therefore, if there's less oxygen, less blood pressure, correct? Getting to the kidneys, what will be triggered automatically? Renin-angiotensin-aldosterone system. And what will be automatically triggered also when the hypothalamus senses, oh, it's low blood pressure. ADH will also be increased. So therefore, what will happen to the fluid volume in the body during heart failure? So if the patient is in heart failure, what are they in? Fluid deficit or fluid overload? Fluid overload. Okay, because again, this is automatic. Okay, so it becomes a snowball effect. So what is the trigger again for renin-angiotensin-aldosterone system? Low oxygen, low blood pressure, right? So therefore, is it present in heart failure? Yes, because the heart failed to pump effectively. So what happens to oxygen delivery? What happens to blood pressure, cardiac output? Low. It will increase fluid in the body because of the renin-angiotensin and the antidiuretic hormone, which are automatically triggered. Okay, let's read on. So what will trigger the release? Fluid deficit or fluid overload? Fluid overload. Now, particularly, where did this come from again? Which part of the body released BNP? The ventricles of the heart. Now, what will exactly trigger this? It is actually the stretching of the heart muscle. What will cause the heart muscles to stretch? Why did it stretch? It's a muscle, correct? Why did the muscle stretch? So imagine that my heart right here, particularly just the ventricles, never mind the atria. What will cause my ventricle muscles to stretch? Fluid overload. So that means how much blood is inside the ventricles? A lot of blood is in there. That means where did all this blood volume come from? Did the patient drink all this water? It came from the renin-angiotensin and the antidiuretic hormone response. So did the patient make urine normally? No, it reabsorbed all the water, all the sodium, increasing blood volume, stretching the ventricles, and as a result, BNP will be released. Now, why did the ventricles release BNP? Read on. Thank you. Okay, if the effects of BNP is opposite the renin-angiotensin system, what is the renin-angiotensin response again? What are those two effects of the renin-angiotensin response? Blood vessels will, how again? Vasoconstriction and reabsorption of sodium and water, right? So if the effect of BNP is the opposite, what is the effect of BNP? Vasodilation, and what will happen to the...
Sodium excretion.
Okay, so there will be sodium loss and water loss. Okay, so is that diuresis? Yes. So therefore, the effects of BNP are diuresis and vasodilation. Okay. Whereas, what is the effect of renin-angiotensin?
Increased blood
Those are
pressure and
vasoconstriction and
sodium water.
and increased blood volume. Any question on these two? So therefore, how many did we have in how many responses do we have for dehydration? Yeah, 2 in the textbook, but in this chapter, but remember sympathetic nervous system?
What was the question?
How many responses do we have during dehydration? Renin-angiotensin aldosterone system, antidiuretic hormone, and not mentioned in this chapter is sympathetic nervous system, which has the same triggers as the renin-angiotensin system. But it's not mentioned here because this is not the adrenal section. But yes, we have 3. How many do we have during fluid overload? Only 1. Only the natriuretic peptides. Did you read anything else? Only 1. So what can you say about the human body? Which are we more efficient at during dehydration or during fluid overload? Dehydration. We're more resilient with dehydration. Not very good at fluid overload. We're helpless. Okay, only natriuretic peptides. That's your only response. Now, since BNP is only and exclusively released by the ventricles of the heart, what is its use clinically? What is the significance of BNP? What is it useful for? Very good. So when BNP levels rise, what's the only explanation? Patient is in heart failure. And what are the other conditions mentioned here again? Valvular heart disease, coronary heart disease, renal failure. Because therefore, in these conditions, what is the patient's fluid status in these conditions? Fluid overload. So renal failure is in fluid overload, coronary heart disease, fluid overload, valvular heart disease, because this causes heart failure as well, fluid overload, right? And so on. Understand? Any questions? Okay, let's take a break. Come back at 1:05.